In this video, we're going to show you a lip lift that I performed on an amazing patient. I'll walk you through the entire procedure. Uncensored footage is up on our Patreon if you want to check that out. Link in the description below. Let's start with some patient background. This is a 30-year-old healthy woman who wanted a shorter philtrum to improve the balance and harmony to her face. Of note, 10 years prior, she had had a rhinoplasty and a chin implant. The rhinoplasty procedure oftentimes will disrupt some of the lip musculature, and therefore it leads to an elongated philtrum. Also, as the nasal tip is rotated up with many rhinoplasty procedures, more of the philtrum is now exposed. So people then worry about that distance and look to get it shortened. When you look at a comparison of other procedures that could be done to the lips to enhance volume, for example, the options are lip lifts, lip filler, lip flips with a neurotoxin such as Botox, lip threads, and V-to-Y lip advancement. Those are all ways that you can get a bit more lip volume. However, the only procedure that will reliably reduce the philtral length is the lip lift. The biggest disadvantage, of course, of the lip lift is the subnasal scar. And coming up in the video, I'll show you how we try to minimize the formation of unfavorable scars. Please make sure to subscribe to this channel. The lip lift process starts with proper patient selection. Most patients are candidates for this surgery. That's not to say that everyone's a candidate, but a lot of people are. It's just about customizing it to fit their particular face. I look for philtral distances of at least 10 millimeters before agreeing to do someone's surgery. Also, it's important to keep in mind the way that the lip architecture is as far as the shape of the upper lip, and for people to keep in mind that the corners don't really rise up along with the rest of the lip because we're doing most of the lifting under the nose. So it's that central 2/3 of the lip that actually go up. It's important when you're looking at how people's starting anatomy is and also considering what their goals are for their final outcome. As far as our patient goes, her goal was primarily to just shorten that distance between the nose and the upper lip to restore some balance to her overall facial anatomy. The next part of a lip lift procedure is the measurements. We use very small calipers to properly measure that distance between the base of the columella to the center of Cupid's bow. In our patient, that distance was 16 millimeters. Some people ask me what the ideal distance is, and I tell them there really is no ideal distance. It just depends on each individual and what they're starting at and what their face allows as far as how much can be removed. You don't want to do too little where it doesn't look like much has changed. You don't want to do too much where now they start to look unnatural. We do a simulation where I try to determine how many millimeters would be best to remove. And we do this with a mirror in front of the patient, as you can see here. It's really a dialogue between myself and the patient, and also with my nurse and others in the room who can also give an opinion about what they think would be best, but ultimately the patient decides how much to remove based on this type of manual simulation. After we completed the simulation for our patient, the plan was to excise 6 millimeters, bringing her predicted philtrum to a 10 millimeter length. The next part is to do the markings. This is a very important step because this is what allows me to properly make incisions once I actually start the surgery. We begin the markings out laterally, where the ala, which is the side of the nose here, starts to go from a vertical type of orientation to a more horizontal orientation. That's where I begin and end my markings. I follow the anatomy of the base of the nose, and I stay underneath the nasal sills as I come across from lateral to medial. Sometimes we make little adjustments with the use of arrows so as not to change the markings entirely, but just to tell me that when I'm actually making my incision, I'm going to follow either the inner aspect of the blue marking or the outer aspect of the blue marking. So that is something that we determine before we start putting the anesthetic into place. I also make some vertical markings which allow me to better approximate the tissues at the completion of the surgery. In addition to the vertical markings, I also use methylene blue to make additional markings along those vertical lines so that at the end of the procedure, if the blue markings have been wiped away just as we're working. The methylene blue is like a dermal tattoo, so it stays in place, and again allows me to better bring the tissues together in a more accurate way towards the end of the surgery. Once we're happy with the markings, then we move on to the anesthesia. For this surgery, we usually just use local anesthesia, which is like when you go to the dentist and you get shots to numb up the area. We do something similar. I start with what's called blocks, so a regional block, which involves making it an injection underneath the lip. So you'll see that here, and we use something that's a bit concentrated as far as the actual anesthetic goes to allow the area to start to go very numb. And then we go from the outside of the skin and we further numb up the area with more medication until the area is completely numb. It's important before we start the actual surgery to properly sterilize the face. We use betadine. For that, we also have patients use chlorhexidine wash the evening before their procedure or the morning of their procedure, and that helps ensure that we have a nice clean area before we start the surgery. The next step is to begin to remove the skin. So I always start on the left-hand side just for pure ergonomics, and I'm able to hold the gauze in my left hand to help me control any bleeding that might come. We use a very precise type of blade to make the incision. I initially score the incision and then we end up going a bit deeper. I use the blade exclusively as opposed to using some scissors, which some people use, or using a cautery or like a laser device. I prefer to use the blade because I have the most control with that instrument. And the skin is removed down to the level of the muscle. So that's what makes it a deep plane lip lift, in the sense that we're going right up to the fascial layer above the muscle surface. We're going underneath the smaz and underneath the full thickness of the skin. The skin tends to be somewhat thick in the lip, and especially in our patient, we found that her skin was particularly thick, which made this part of the procedure a bit more challenging. Once the skin is removed, I then raise what's called a flap, essentially separating the skin from the muscle. The purpose of creating a flap is to reduce tension on the closure, so that when things finally heal, it ideally heals into a thin line along the incision line, so that the scar is as minimal as it can possibly be. That's always our goal. Like I said, the skin flap in our patient was a bit thick, but we were able to create a nice even flap all the way around. You can see me initially starting with a scissor to begin the elevation of the flap, but then I turned back to a fresh blade to allow me to fully create and extend the flap. We use bipolar cautery, which is a way to stop the little blood vessels from bleeding. Remember that the head and neck is a very vascular area, and the lip included. So it's important to have the right equipment in place to control and to stop any little blood vessels that may ooze during the procedure. I'll also mention that our patient was actually quite oozy. As you can see in these videos, she had more bleeding than some of our other patients, but you need to be prepared when doing this type of surgery for different amounts of bleeding. And we're always ready, always able to control that bleeding. The next step, once the flap is elevated and the bleeding is controlled, is to apply the deep sutures. These are dissolvable sutures that are placed in these key type of locations to allow proper approximation and bringing the skin together from the nose to the remaining lip. These sutures have to be placed in a deep level. So they're not placed in a way that tethers the skin just from right under the skin. Instead, they're placed at a deeper point so that the skin is actually quite loose and able to still breathe and have some degree of movement. But the tension is held lower down in the flap. In our patient, what you'll see is that we actually had to repeat some of the deep sutures. We want to make sure that every single deep suture is applied accurately and that it's really doing the job that it's meant to do. Sometimes we apply a suture and we find that the levels are a bit off, and instead of just accepting that as that's just how it is and rushing to finish the procedure, we take a step back, we release the suture that we don't like, and we just redo the process. I use tapered needles to allow me to go back, redo and not just tear through tissue. So everything is done with a lot of thought in mind about potential repercussions and what we need to do if we need to execute plan B or if we need to go back a step. Once the deep sutures are in, we next assess for symmetry. Even though there's local anesthetic in the area, I'm still able to judge for symmetry. And this does not apply to the entire length and full amount of the upper lip. There's no way to perfectly make the entire lip symmetrical. Almost everybody starts with some degree of asymmetry, and some people think that with the lip lift you can get the upper lip perfectly symmetrical across the entire length of the lip, and that really just isn't true. But what we can do is to make sure that at the level of the Cupid's bow, at least, that central bit, that we're able to get the height of the Cupid's bow from one side to the other to be as even as we can possibly get it. And if we find that one side is higher than the other, then we go to correct that with additional skin excision until we're happy with the level and the height. In this patient, we were able to properly align the height of the Cupid's bow and the upper lip from the initial suturing. And so we didn't have to go back and revise that element of it. Once we're happy with the symmetry, we then move on to suturing the skin layer. And I do that with non-dissolvable suture that I have to remove at 5 to 7 days. You can see how carefully we place this Prolene suture to make sure that we have great alignment and eversion of the skin at every single point along the incision. Once the suturing is complete, we then wipe away all the betadine and any dry blood that may have occurred in that area, and then we proceed to put on a bandage. And I use a combination of Telfa, antibiotic ointment, and some tape to apply this bandage that will stay on for 24 hours. Please check out our video on lip lift healing for more information about the post-operative healing process and general wound care instructions for after the lip lift surgery.